We got the MCQ. So this is the 2018 AL MCQ. As you know, the medicine final MBBS MCQ has 30 true false MCQs, and then it also has 20 SBA MCQs, right? So when you try to attempt the MCQ paper in medicine, you need to remember that when you are trying the true false MCQs, you need to remember that these true false MCQs, you have to at least answer 3 to 4 steps if you need to pass the exam, and you have to be absolutely 100% sure when you give the answers to these MCQ stems, because uh, if you don't answer properly, you will get negative marks, and the total mark that is given for the question will be deducted. So be very careful when you are writing true false. It's okay not to know answers to some true false. The structure of the paper is such that sometimes the hard true false MCQs are in the first part of the paper, and some the easy ones are in the middle and the end. So don't be disheartened that you are unable to answer the beginning MCQs properly, right? You can of course do well in the later of the paper. So when you don't know the answer to something, just circle it and go. Okay. Okay. So we go to the first MCQ.
We
Lesions.
have 20 true false no Masha.
Right.
30
Sorry.
arakene
Yeah.
saiki velade.
Yeah. Sorry. So lesions which cause hemianopia. Hemianopia is when one part of the visual field of one eye is lost, right? When one half of the visual field of one eye is lost, it's called hemianopia. This can be bitemporal, or this can be unilateral, or this can be contralateral, right? Bitemporal, this can be unilateral, not really unilateral. This can be bitemporal or contralateral uh, hemianopia, or there is also something called ipsilateral hemianopia also, right? So hemianopia comes now. This is essentially basically testing your knowledge about the neuroanatomy, right? This MCQ is entirely about that. So you guys know the optic pathway where light enters the eye, and this light is bounced off into the retina, and the nerve signals are then taken along the optic nerve, and this optic nerve becomes the goes to the optic chiasm, and then after the optic chiasm there is a decussation at the optic chiasm, and then after that it becomes the optic tract inside the brain, and the optic tract then goes into the optic cortex, right? Not really the optic cortex, the visual cortex in the occipital lobe, right? And part of this optic tract goes into the midbrain as well, to form the component of the pupillary light reflex, right? So this is on both sides of the brain. So this forms the right and left parts of the optic path, right? So this forms the right and left sides of the optic path, right? So yeah. So basically, the optic chiasm is in the middle, and then optic tract, and then the midbrain is also in the middle, and then optic cortex is bilaterally there, right? The optic chiasm is shared by both sides. Optic tract is also shared by both sides. And then it goes into optic cortex on either side. Now you need to remember the how the fibers decussate, because there are nasal fibers which come from the nasal half of the retina, the part which is closer to the nose, and then there are also temporal fibers which come from the temporal half of the retina, which come from the temporal half of the retina. So the temporal fibers of the temporal half of the retina take light from the light coming from the nasal half. We can nasal half එකකින් light තමයි carry කරන්නේ temporal part of the retina, and the nasal part of the retina carries light coming from the temporal part of the visual field, right? So you need to remember what happens when each of these parts in the visual field pathway are damaged. What sort of visual field defect do the patients get here? You need to know. Okay, so remember, in a patient who loses sight in one part of the eye, either the eye is damaged, or the retina is damaged, or the optic nerve is damaged, usually you get ipsilateral blindness. So the same side where the damage occurs, you can't see at all. So that is called ipsilateral blindness. Understood, right? So this is the type of defect you get for all lesions taking place above the optic pathway, before the optic chiasm, right? Before the optic chiasm, right? Before the optic chiasm, all lesions are unilateral, right? So where the damage takes place, that side is the one that is going to be defective. In the optic chiasm, if there is damage to the optic chiasm, remember there will always be only one type of visual field defect, and that is bitemporal hemianopia. Bitemporal hemianopia, if you elicit in a patient, that is of course only seen in patients with optic chiasm lesions. Understood? Another, if you get a patient with bitemporal hemianopia, the lesion has to be in the optic chiasm. That is a golden rule. They cannot be in anywhere in the visual field pathway or the visual pathway, right? That is one rule. And then, with your knowledge in neuroanatomy, the temporal fibers go like this, and they go to the same side occipital lobe. However, the nasal fibers, they decussate, right? So they decussate to go to the opposite side of the occipital cortex, right? So this is the visual field pathway, so you need to know this. So if there is a problem, in the lesion behind the optic cortex, say for an example, there is a lesion in the optic tract or the occipital cortex or anywhere here or here, there will be there will be hemianopia, right? So hemianopia comes when one half of the visual field is defective, right? So here the temporal halves of the visual fields are defective. Here, if there is a lesion here, right? There's a lesion here, what will be defective? The temporal half of the fibers taking nasal signals will go off, and then here also in this side, the nasal half, the temporal half of this side's visual field will also be defective, because this is carried by this cable here, right? This is carried by this cable, and then the nasal stimuli coming from this side is carried by this cable. So these are the two cables that will be defective. So the defect that you will observe in either eye will be like this, right? Will be like this. Understood? There no the
Oh, yeah.
right. So just like that, if so, the defect is in the same side. However, you can note that the injury or the lesion is on the same side. However, the defect is in the opposite side, right, of the visual fields. So this is contralateral hemianopia. Understood? This is contralateral hemianopia. They can ask something else also in the optic pathway. What happens when you get a lesion in the occipital cortex? In the occipital cortex, you will lose this visual field, but the macula will be spared, right? Understood? So macular sparing will be seen if there is a lesion in the occipital cortex, right? So those are the things that you need to understand. So if there is a patient with bitemporal hemianopia, the lesion is always in the optic chiasm. That is the first rule. You understood? And then always, if the lesion is above the optic chiasm, the defect is on the same side of the same side as the lesion. And always, if the defect is behind the optic chiasm, the lesion is the defect is always on the contralateral side, and always hemianopia. To have hemianopia, you need a lesion at the chiasm, or you need a lesion behind the chiasm, right? Understood? Jahanna, did you understand the rules?
Yes.
Okay.
Yes.
So lesions which call hemianopia, optic chiasm lesions do cause hemianopia. What type of hemianopia does it cause? Bitemporal hemianopia.
Bitemporal hemianopia.
Right? Frontal lobe, does it cause hemianopia? No. Why? Because
No.
it is not involved in the occipital pathway. Right? And then optic nerve lesions, can it cause hemianopia?
No.
No, it cannot cause hemianopia. It causes ipsilateral blindness. Optic tract, does it cause hemianopia?
Can.
Yes. Why?
Yeah,
Because it
yeah.
is behind the optic chiasm.
Behind the optic.
Optic occipital lobe, will it cause hemianopia? Yes.
Yeah.
Why? Because it is behind the optic chiasm.
Optic
Understood?
chiasm. Yeah.
Yes.
So that is the rule that you use to get these answers to the MCQ. So someone can also argue now this optic nerve, and then you have the optic. There is something called the optic radiation, right? So optic tract, and then there is something called the geniculate body here, some additional thing that I'm mentioning, and then from that, this optic tract becomes the optic radiation, right? So this optic radiation is also some additional part, but if I can remember, this optic radiation is involved not in the frontal lobe. It is involved in which lobes of the brain? The optic radiation is involved in the parietal cortex and the temporal cortex, parietal lobe and the temporal lobe. So if there are lesions in the parietal lobe or the temporal lobe also, that can cause defects in the visual field and can cause hemianopia. Understood, Lamai? Right? So that is how you identify the visual field defects. And what sort of defect will it be? Will it be ipsilateral blindness or hemianopia? If there's a lesion in the frontal lobe, if there's a lesion in the parietal lobe or the occipital, temporal lobe.
Wait, repeat the question.
So now this optic tract goes to somewhere called the lateral geniculate body. That is an additional detail which I didn't mention here. That
Okay.
also goes and radiates to the optic occipital cortex, right? So
Mhm.
sometimes there can be lesions in the parietal lobe and the temporal lobe which obstruct the optic radiation. In that case, right? What
Mhm.
sort of defect will there be? Will there be hemianopia?
Yes,
Yes. Why?
it's
Because
behind the optic eyes.
excellent. So it is behind the optic chiasm. So parietal lobe and temporal lobe lesions can also cause hemianopia. Understood? So now we go into the next MCQ. Not hard at all if you know the rule, neither. Right? So features,
Yeah, but when we don't know, it's very confusing.
yeah, if you don't know, it's hard.
Yeah.
Features in early stage of idiopathic Parkinson's disease. Now, there is a, pathway in the brain called the basal ganglia system, right? So, pathways of the brain, there is a system called basal ganglia system. What are the components of basal ganglia system? That day I told you. There is something called putamen, and then there is also something called globus pallidus, right? Putamen, globus pallidus, and then there is also something called substantia nigra, right? Substantia nigra, and then I also said there is something called uh, what do you call this, subthalamic nucleus, right? Subthalamic nucleus. So these are the parts of the basal ganglia system, and this basal ganglia system has dopamine, right? As dopamine as the neurotransmitter. So now when there is a lesion in the dopaminergic pathway, in the pathway of the brain that has these components, that will cause a combination of symptoms called what? Parkinsonism. So I mentioned that day, Parkinsonism can be due to many causes. The commonest cause is actually idiopathic Parkinsonism. What are the symptoms of Parkinsonism that you guys know of?
Uh, intention, no. Tremor,
Skin tremor,
Resting
rigidity,
tremor,
resting tremor,
rigidity,
resting tremor, pill
rigidity,
rolling tremors,
and then what else?
shuffle,
asthenia,
Uh,
bradykinin,
bradykinesia or akinesia, and then what else?
and Parkinsonism.
Postural instability.
Oh,
postural
sorry.
instability.
Please, postural instability.
But postural instability is not a feature of early Parkinsonism. This is a feature of late Parkinsonism. Understood? So, when there is a lesion in the subthalamic nucleus, or when there is lesion in the substantia nigra involved in dopaminergic pathway, especially when there is a lesion in the substantia nigra, right? When there is a lesion in the substantia nigra involved in dopaminergic pathway leading to death of neurons in the substantia nigra, the Parkinsonism that is present in the patient is called idiopathic Parkinsonism. The reason is neurodegeneration. Understood? So we don't know why this Parkinsonism took place. For some reason, the nerves in the substantia nigra have been going dead. So all the dopaminergic pathways in the substantia nigra are diminished. So because of that, what you get is called idiopathic Parkinsonism. And then you get something called atypical Parkinsonism. What are the causes of atypical Parkinsonism? Atypical Parkinsonism you get due to a problem in the dopaminergic pathway, but it is not directly due to neurodegeneration in the substantia nigra. What are the causes of atypical Parkinsonism?
Vascular Parkinson's.
Vascular Parkinsonism. Anything else? Hello.
Eight.
Right. So when you talk about Parkinsonism as atypical Parkinsonism, that is also Parkinson's-like features, but they are not the classical features of normal Parkinson's disease. Understood? So the reasons for atypical Parkinsonism are: number one, there is something called progressive supranuclear palsy, right? And then there is also something called all these dementias with that involve the dopaminergic pathway. What are the dementias involve the dopaminergic pathway? Frontotemporal dementia, right? And then this can also involve the some other dementias which cause dopaminergic pathway destruction is dementia with Lewy bodies, right? In psychiatry you might be knowing these things. So these also present with Parkinsonism, but these are having atypical features. So how do you determine whether Parkinsonism is idiopathic or atypical? It's always a clinical diagnosis. Understood? So there are certain features in early Parkinsonism, and there are certain features in late idiopathic Parkinsonism. Usually what happens in atypical Parkinsonism is that the late Parkinsonism features present first. However, in idiopathic Parkinsonism, the late features are always late. What are the late features which present early in atypical Parkinsonism?
Postural instability.
Yes, postural instability comes early in atypical Parkinson's. What else? They get bladder bowel dysfunction early, or they actually idiopathic Parkinson's is not very common to get bladder bowel dysfunction, but these patients with atypical Parkinsonism get bladder bowel dysfunction early. Understood, right? And then what else can they get? They can get what else, guys? They can get gaze palsies. Gaze palsies are movements of the eye. They can get defective movement of the eye muscles. So extraocular muscle paralysis and discoordination can take place, right? So these things come early in atypical Parkinsonism. And also, you can see what you can get neurocognitive difficulties. Why these patients with dementias they present with early Parkinsonism, sorry, atypical Parkinsonism. So neurocognitive defects come as a part of the atypical Parkinsonism. Understood?
Yeah.
And
Yeah.
also in atypical Parkinsonism, there is involvement of the cerebellar and also the pyramidal tracts. What are the pyramidal tracts? What do you mean by pyramidal tracts? So cerebellar signs and pyramidal signs are also there. What are the pyramidal signs? Upper motor neuron and lower motor neuron signs, especially in upper motor neuron signs, because the Parkinsonism is taking place in CNS. So all these things will come in Parkinson's disease, idiopathic Parkinson's disease also, but it will come at a later stage, right? However, in atypical Parkinsonism, in conditions like dementias and progressive supranuclear palsy, where the same dopaminergic pathway is altered, but it is not due to idiopathic neurodegeneration. It is due to some other cause like demyelination or something else, right? And it does not take place in the substantia nigra specifically at the beginning. So these things will cause these symptoms as the first sign. Understood? In idiopathic Parkinsonism, these things will come later, usually after 10 to 15 years of diagnosis. Understood? Arunaja.
Okay.
Yeah.
Yeah. Yeah.
So, something you also need to know now, this is actually primary Parkinsonism. Primary Parkinsonism means that it is due to neurodegeneration, but it is actually due to neurodegeneration. Killer. Remember, in atypical Parkinsonism, also neurodegeneration takes place, but it doesn't take place like in atypical Parkinsonism at substantia nigra specifically. It takes place in other areas of the brain also, right? In primary Parkinsonism, there is always neurodegeneration. What are secondary causes of Parkinsonism? Hello. What are secondary causes of Parkinsonism? Have you heard of strokes leading to Parkinsonism? If there's a massive stroke in the basal ganglia pathway, that will lead to Parkinsonism. However, it is not due to neurodegeneration, it is due to ischemic injury. And then if there is something like, what do you call this, drugs, psychotropic drugs, like what you give for schizophrenia and manic disorder, the mood stabilizers and the antipsychotics, right? So they can cause problems in the dopaminergic signaling of the brain and they can cause Parkinsonism. That is not due to the neurodegeneration, but it is due to the secondary drugs that are involving and defecting and disordering the basal ganglia circuitry, right? Understood? So if something is there due to idiopathic nerve injury and destruction, that is called primary Parkinsonism. Out of primary Parkinsonism, there are two types: idiopathic Parkinsonism, atypical Parkinsonism. Idiopathic Parkinsonism takes place specifically at the beginning at the substantia nigra. Atypical Parkinsonism also due to neurodegeneration, however, it takes place due to neurodegeneration at other places than substantia nigra, right? So in Parkinson's disease, you will anyway have in both idiopathic and atypical Parkinsonism the signs called TRAP, tremor, rigidity, akinesia, and postural instability. However, in idiopathic Parkinsonism, these symptoms will be late. In atypical Parkinsonism, these symptoms will come early. That is how you clinical differentiate the two. Apart from the causes of neurodegeneration, there is also some causes which lead to secondary Parkinsonism due to destruction without neurodegeneration of the basal ganglia, and those examples are strokes and psychotropic medications. Understood? Ternada?
Yeah.
Yes.
Over.
So with that knowledge, we'll go to the next one. Features early stage of idiopathic Parkinsonism. So this is normal, the generic Parkinson's disease which we described. Unilateral tremor, true or false? Early stage.
True, ne?
True. Which side is more common to get Parkinson's tremor? Left or right? Left, right? Usual patients get left-sided, slow frequency, resting tremor. Right? Understood?
True.
And then postural hypotension.
False.
Postural hypotension, is it true?
False.
Autonomic nerve involvement, bladder, bowel, sexual dysfunction, and also postural hypertension is early feature of atypical Parkinsonism, not idiopathic Parkinsonism. MMSC being 29. MMSC is usually 24 or less is abnormal, right? 29 means normal MMSC. So, is this normal for early stage of Parkinsonism? Yes.
Yes.
Yes, because this is not due to dementia like Parkinson's disease, which is atypical Parkinson's. There you get cognitive decline as an early feature. Understood? Symmetrical hyperreflexia.
No, very
False. Not a feature of
Okay.
early Parkinson's. Cerebellar signs.
false.
False. Not a feature of early idiopathic Parkinson's disease. Understood? Shall we go to the next one?
Yes.
Okay.
Okay. 29, third one. 69-year-old male is managed in the ward following an anterior STEMI. On day 3, he becomes dyspneic. Which of the following are possible causes? So, dyspnea is most likely due to what? Heart failure, acute heart failure. Right? That is the commonest cause of dyspnea in patients with MN. So, acute heart failure, what are the causes for acute heart failure in a patient who has undergone anterior STEMI? So, anterior stem is supplied by which artery? Anterior area of the myocardium? Left anterior descending artery. Ne? Right? So, pericarditis. Can this be a cause of dyspnea in a patient with anterior STEMI? Yes. What is this syndrome called? Pericarditis, and they will also have cardiac effusion, right? Pericardial effusion. What is this syndrome called? Where you get a pericardial effusion 3 to 5 days after a myocardial infarction. What is that called? That is called Dressler's syndrome. read around that. Restless syndrome. This is a common complication, right? Left ventricular systolic dysfunction. Is this true? Can this be the cause of dyspnea? Hello.
Yeah, neither.
Indeed,
Yeah,
yes.
Can be, no?
true. Papillary muscle dysfunction. Can this be a cause of dyspnea?
Yes.
Yeah.
Yes.
Yeah.
Pleural effusion. Can this be a cause of dyspnea?
Black.
Can
Yeah.
That
Can
can
be,
be a
no?
cause of
Black
dyspnea.
pressure.
However, this is sometime not that, indirectly we can take pleural effusion as a cause of dyspnea in acute heart failure, because if the patient is having acute heart failure, they will have uh, small pleural effusions due to the heart failure itself, right? Due to the heart failure itself. So sometimes acute heart failure may lead to pleural effusions, and that can, of course, cause problems with dyspnea in these patients. However, we leave it for the time being because that is not one of the major causes, right? Intraventricular septal rupture. True or false? Can this
True.
take? Huh?
No idea.
That can take place. Remember when we went to see short cases, we saw a patient with VSD adult.
Yes.
So that patient could have had a MI, and then following that, 3 to 5 days, there is coagulative necrosis of the tissue that the MI has undergone, and that is where the tissue is the weakest. So because of that, the tissue can undergo rupture, right? What is the other
Okay.
cause? What is the other commonest cause for acute heart failure in a patient following a myocardial infarction? Arrhythmias, right? So ventricular fibrillation, ventricular tachycardia, all these things have a high predisposition after myocardial infarction. So they can, of course, get arrhythmias, and the arrhythmias can precipitate acute heart failure. Understood?
Yes.
Yes.
Okay, we
Yes.
go to the next one. Regarding hemodynamic changes in mitral stenosis, increased left atrial pressure. True or false?
True, no?
True. Why?
True.
Siduro body and
Because left
left right.
atrium, the left ventricular filling is delayed
Delay.
due to the mitral valve being stenosed. Reduced cardiac output. True or false?
True.
True. Cardiac output is reduced. Why?
Reduced.
Because
Because of
Reduced feeling of
yeah,
the
left
left
feeling.
ventricular
ventricle.
filling is obstructed due to the mitral stenosis. Right? Pulmonary hypertension. True or false?
Yeah. True.
Yeah.
Why? Due to
Because back pressure.
Back pressure.
yes, due to back pressure transmitted from the left atrium into the pulmonary veins, pulmonary arteries. Sorry, not the pulmonary veins. Left ventricular hypertrophy. True or false?
Yeah.
False,
True.
neither.
False. Left
False.
ventricular hypertrophy
False.
does not take place. Why? Because there is no obstruction to the left ventricular
Obstruction.
outlet. Right? No
Okay.
obstruction at the left ventricular outlet.
Okay.
What leads to left ventricular hypertrophy?
Out. Aortic valve.
Aortic
Aortic
valve.
stone.
Aortic
Aortic
stenosis.
Aortic
stenosis.
Good. Right
Okay.
ventricular hypertrophy. True or false?
can be, no?
Can. In what condition?
Back. For
Congestive
back.
heart.
In chronic mitral
Chronic
stenosis with severe pulmonary hypertension.
severe pulmonary.
Severe long-standing pulmonary hypertension. Understood?
Okay. Is it because of like back pressure?
Yeah, because now, not back pressure. Now, if you take the heart like this is the left atrium, mitral valve, left ventricle. This is the right atrium, right ventricle, and then this is the pulmonary vein. This is the pulmonary. This is the aorta, and then this is the pulmonary artery, and this is sorry. This is the pulmonary vein. Uh, this is the aorta. This is the what do you call the pulmonary artery, and this is the superior vena cava and inferior vena cava. So stenosis is taking place here, no? Right?
Yeah.
So both of these two are connected with the lung. Understood?
Mm.
So when there is stenosis here, the pressure here increases. The left ventricular filling reduces, so the cardiac output reduces. When the pressure increases here, that leads to transmission of the pressure into the pulmonary circulation and pulmonary hypertension. The pulmonary artery is the outflow tract of the right ventricle. So when there is increased pressure here, there is pressure overload of the right ventricle. When there is pressure overload, like in aortic stenosis for the left ventricle, there is hypertrophy. Understood?
Okay.
Okay. So we go to the next one. Regarding COPD, digital clubbing is a feature. True or false?
False. False.
You get digital clubbing in what conditions?
Interstitial lung disease,
In
bronchiectasis.
interstitial lung disease, bronchiectasis, any other
Bronchiectasis, lung carcinoma,
lung cancer. What else?
Um,
In empyema and lung abscess.
empyema.
Right? These are only the respiratory causes for clubbing.
clubbing.
Right? Alpha 1 antitrypsin deficiency is a causative factor. True or false?
True, no?
True, right?
True, no?
What does
Yeah.
alpha 1 antitrypsin do?
Mm,
It inhibits macrophage
Macro.
proteolytic enzymes. So when the macrophage proteolytic enzymes are uninhibited, they can cause destruction of the alveoli and COPD. Understood?
Yeah.
okay.
Secondary polycythemia is a complication. True or false?
True, no?
True.
Why?
Why side?
Why?
Saturation. Oxygen, hypoxia.
Due to chronic hypoxia. Okay. Target oxygen saturation in a exacerbation is 94 to 98%.
False. False.
False. Usually, what is the target saturation?
88, 9,
88 to 92%. Why?
92. අර ඩ්‍රයිව් එක අර කාබන් මේ ඩ්‍රයිව් එක තියාගන්න ඕනේ දර.
Yeah. Usually, patients with COPD are chronically hypoxemic, so their respiratory drive is driven by hypercapnia.
Hyper.
So if we give too much oxygen, there will be carbon dioxide washout, and because of the carbon dioxide washout, they will have what? Sorry, Arunaja.
වැරදිුණනේ.
Oh, usually COPD patients are chronically hypercapnic.
Hypercapnic.
Yeah, so they have hypoxia as the respiratory drive. So when there is hypoxia, when the oxygenation actually improves the saturation, what will happen? This hypoxic drive will be gone. So they will not breathe. So because of that, everything will worsen because the respiratory drive will not work in these patients. Understood?
Yep.
Long-term oxygen therapy has survival benefit in selected patients. True or false?
True.
True, no?
True. LTOT or long-term oxygen therapy has survival benefits. Right? What else? What are the other diseases that long-term oxygen therapy is given for?
Interstitial lung disease.
Yeah, any chronic lung disease, including interstitial lung disease, bronchiectasis. Does it improve survival in these diseases also? Yes,
No.
it does improve survival. Survival is improved in these conditions, in these diseases also. Understood?
Okay.
Yes.
Okay, so we go to the next one. Regarding bronchiectasis, you see the same questions are asked from the same subject areas. But allergic bronchopulmonary aspergillosis causes central bronchiectasis. True or false?
True.
True.
True, no?
Actually, I also don't know, right? So these things, these MCQs actually come about like this. So you won't know the answers to every MCQ step. So just leave it and go to the next one. Presence of pseudomonas in the sputum culture is poor prognostic sign. True or false?
Pseudomonas in the poor.
True. Why? Because pseudomonas is an aggressive gram-negative organism. It will lead to recurrent respiratory tract infections. and it will further worsen the bronchiectasis. Understood? That is why we do
Okay.
Pseudomonas decolonization in patients with bronchiectasis. Another. Understood?
Yes.
Airway obstruction is frequently seen. True or false? True.
True.
Why? Because of large mucus
Obstructive.
plugs. Right? Understood?
Yes.
Sputum culture is essential for diagnosis. True or false?
Not essential.
Pause, no? Not essential. Clinical. Right.
This is for what? Pneumonia
Mm.
or something like TB. Right? What do you
Okay.
do for bronchiectasis to diagnose bronchiectasis? CT,
Bronchoscopy.
HRCT.
CT.
HRCT.
There you can see the dilated bronchi. Understood?
Mm.
Inhaled antibiotics are used in the management. True or false? True. Inhaled gentamicin. Inhaled gentamicin is used in the management of what? Decolonization of this guy, Pseudomonas. Right? Now we'll go to the MCQ step which we don't know.
Okay.
Up to now understood the
Yes.
Yes.
MCQ which we had for our exam is not very hard at all. It's easy, and you guys will get the same MCQ for medicine in this time also. So don't be stressed. Okay.
Mm.
So bronchopulmonary aspergillosis is an infective cause of bronchiectasis, right? The problem is whether aspergillosis cause, what do you call this as, central bronchiectasis. Yes, so apparently aspergillosis does cause enlargement of the central large airways, right? That is just a characteristic feature of allergic bronchopulmonary aspergillosis, right? There is no other way to remember this. I don't know why this causes that. Uh, yeah, so that is true as well. We'll go to the next one. Features of Crohn's disease over ulcerative colitis. Crohn's disease over ulcerative colitis, right? Arthritis. Does it come in Crohn's disease or ulcerative colitis? So both.
Both, right?
Yeah,
Extra.
both. Not only Crohn's disease. This is false.
Yeah.
Bitot spots. What is Bitot spots?
Vitamin A deficiency.
Yeah, due to chronic vitamin A deficiency. Is it more common to get in ulcerative colitis or Crohn's disease?
Mm.
More common to get in Crohn's disease.
Crohn's
Not
disease.
why?
Small intestine.
Yeah, small intestinal manifestations are common in Crohn's disease, not
Crohn's disease.
ulcerative colitis. So this is true. Oral ulcers common in Crohn's disease or ulcerative colitis?
Crohn's disease.
Crohn's disease, true. Prolonged PTINR,
Vitamin K deficiency.
vitamin K deficiency. But can ulcerative colitis also cause vitamin K deficiency?
Can
How? Because ulcerative colitis involves the large intestine predominantly, the ascending colon, the transverse colon, the descending colon, and the sigmoid colon. You know that the vitamin K producing bacteria are mainly produced in vitamin K producing bacteria are mainly housed in the large intestine. So when the normal flora of the large intestine is changed due to ulcerative colitis, it can cause reduction in the endogenous vitamin K levels. Understood? So
Okay.
because of that, they can get vitamin K deficiency. In the same time, Crohn's disease patients have small bowel involvement. So duodenum is where all the fat molecules are absorbed. So with the fat molecules, with the chylomicrons, actually the vitamin K is also absorbed together with that. So if there is small bowel involvement in Crohn's disease, they can also get vitamin K deficiency. So personally, I would not attempt this MCQ stem because we need to remember get only 3 to 4 stems. No? So with that,
Yeah.
we'll go to the next one. Increase CRP, feature of both diseases or one disease.
Both.
Both. So we can't take this. Why? Because both are inflammatory bowel diseases.
Inflammatory cases.
Yeah. What about this thing? Fecal calprotectin. Will it
Crohn's, no?
increase in one disease,
Matakai.
other disease, or both?
Both.
One is
Not
Crohn's.
sure.
Both. Right? So they can give this as the stem in the next time. Right? Okay. So we'll see what type of PTINR elevation cause PTINR elevation is caused by ulcerative colitis and Crohn's disease separately. Yeah, so apparently both diseases can cause elevation of PTINR. So it is a good thing that we didn't actually attempt this MCQ. So apparently both diseases can cause. So you need to know how to differentiate ulcerative colitis and Crohn's disease clinically. But how do you differentiate it in the diagnosis? How do you differentiate it in the diagnosis? Hello.
Yeah.
How do you differentiate the diagnosis? How do you come to diagnosis of these diseases?
Involvement of the parts.
Yeah, that is one way
Right.
of the part. But sometimes both ulcerative colitis and Crohn's disease can involve the large colon. That can take place, no? Because Crohn's disease can affect the large colon also separately. Then how do you differentiate these two from each other? Then you have to do a lower GI colonoscopy and you have to take biopsies. Right? And the biopsy can confirm what is ulcerative colitis and Crohn's disease. What are the features of seen on colonoscopy on ulcerative colitis, and what are the features seen on colonoscopy in a patient with Crohn's disease?
A cobblestone appearance
In
area.
what disease?
Skip lesion. Crohn's.
Yes, good. Skip lesions and cobblestone appearance in Crohn's disease. In ulcerative colitis, what do you get?
Continue.
Yes.
Continuing.
Yes, you can get pseudopolyps, and then you can also get contiguous lesions. If you see deep lesions, deep ulcerations in the larger or small bowel mucosa, what can the disease be?
Crohn's, no?
Deep fissuring ulcers can be there in Crohn's disease. In ulcerative colitis, the lesions, sort of lesions will you see in ulcerative colitis? You will see large, confluent, superficial ulcers.
Superficial ulcers.
Right? Okay. What about the histological types? Histological differences you will see in ulcerative colitis and Crohn's disease. What are the histological differences? Histopathological, where you look at the biopsy under the microscope, what sort of differences can you see between ulcerative colitis and Crohn's disease? Jarna,
No.
what do you see in ulcerative colitis?
Can't remember.
You can again see pseudopolyps, right? You can again see pseudopolyps. And then what else can you see? You can see there is inflammation extending deep or just only to the mucosa and submucosa.
Mucosa or submucosa, right?
Yeah, on inflammation only tracking up to the mucosa and submucosa. What about Crohn's disease?
It will go deep.
Huh?
Deeper than
Yeah,
mucosa and
inflammation can
submucosa.
extend even up to the serosa, right? And then in which condition do you get crypt abscess?
Crohn's.
Disease. And in which conditions do you get caseous granulomas? Non-caseating granulomas. In Crohn's disease.
Yes.
Remember, these are the features of Crohn's disease on histology. Understood?
Okay.
Yes.
If it involves somewhere other than the large bowel and the rectum, is it always Crohn's disease?
Always given the name.
Can't.
Always
You said-
Crohn's disease, come on.
Is it? Okay.
Yeah.
Yeah,
Oh, okay. Yeah.
You guys. Understood?
Okay.
Yeah.
What did you understand, Jarna?
That if the involvement of the rectus and cecum is there, it is always Crohn's disease.
Excellent.
But Arunaja, didn't you say just before that, when we said that it can be clinically diagnosed because the oral ulcers and all will be there,
Yeah,
but you said
always
that
we can. Sometimes we might be able to see that disease in other areas, and we might be able to diagnose a patient with as Crohn's disease, but not always. Sometimes the Crohn's disease can affect only the large bowel,
okay.
right? And something that I have misplaced is that crypt abscess commonly seen in ulcerative colitis, not Crohn's disease. Huh?
Okay.
I will put a table with histological features, differences, and the clinical features that are used to differentiate ulcerative colitis and Crohn's disease. Okay, to the group. Okay, so we'll go to the next one. Ascites. Portal hypertension is a cause. True or false?
Yes. Yes.
What are the other causes for ascites in a patient with CLCD?
Spontaneous bacterial peritonitis.
Okay. What are the 6 causes for ascites in a CLCD patients? I have told you guys this before. So again, remember, going back to this question, there are clinical features and histological features that are used to differentiate patients with ulcerative colitis and Crohn's disease. Huh? And histological features are also there to differentiate patients with ulcerative colitis and Crohn's disease. Yeah, Deshbandhu? One thing is portal hypertension. What is the second cause for ascites in a patient with CLCD?
Albumin.
Hypoalbuminemia. Good.
Hypoalbuminemia. Then
Portal vein thrombosis.
portal
Portal vein thrombosis. Okay, that also leads to portal hypertension, no?
Okay.
What else? Splanchnic vasodilation can also cause
Yeah,
ascites. What else?
Heart
Lymphatic
failure.
obstruction
lymphatic
Yeah.
obstruction also.
can cause ascites. What else?
Heart failure.
Renin-angiotensin aldosterone system overactivation,
Yes.
Okay.
and then aldosterone accumulation
Mm.
are the 6 causes for ascites, right? Remember those, huh? I'm not going to write
කලින්
them.
කරාව.
කලින් කරානේ.
Oh.
කරාව.
TB peritonitis has a hemorrhagic peritoneal fluid. True or false? True.
එක්සූඩේට් එක එනවා මේ හිමොරජික් එකක් එන්න පුළුවන්ද?
So hemorrhagic එක දෙන්න පුළුවන්. Okay.
එන්න
What
පුළුවන්
is
නේ.
the other cause of hemorrhagic peritoneal fluid?
අර මේ වගේම තියෙන තව එකක් තියෙන්නේ මේ
Peritoneal
TB
carcinoma.
වගේම. පෙරට.
When there is
ඒකනේ.
involvement of the peritoneum, like hepatocellular carcinoma
Mm.
and other cancers like ovarian cancer, that can also cause hemorrhagic peritoneal fluid. Cirrhosis is due to hypoaldosteronism. Hypoaldosteronism. True or false? True or false?
හයිපර්ද? දන්නේ.
Hyper, no.
ඒක දන්නේ.
Oh, hyperaldosteronism.
හයිපර්
Why? Why? There has to be reason, no? It's due to hyperaldosteronism. Why? Because in cirrhosis, the liver is the place where
සිර.
aldosterone is removed. So liver is disease in cirrhosis. So because of that, the aldosterone levels accumulate in the body. Understood?
Mm.
In peritoneal malignancy,
Yeah.
SARC is more than 1.1. True or false?
ලස් ඒ නෑනේ නේද?
Less.
ඒක එක්සූඩේට් එකනේ.
Exudating.
Yeah.
What is
False.
SARC? Jana?
Huh?
What is SARC?
Serum albumin and
Serum albumin to ascitic fluid albumin
Ascitic.
gradient.
ඇසයිටික් gradient.
And if there is exudate, ascitic albumin decrease or increase.
less than
less than 1.5.
If there is
less than
exudate,
1 නේ.
is ascitic albumin increase or decrease?
Citric albumin increase.
Excellent.
Yeah.
Why?
I don't know that.
Why? Because
Transudate.
capillaries are destroyed. Remember, I said exudate is due to inflammation and destruction of capillaries.
Mm.
Due to inflammation. So when there is capillaries destroyed, it causes leaking of albumin. Understood?
Okay.
Salt restriction is the first step in management of ascites associated with cirrhosis. True or false? True. Always. In a patient with cirrhosis, I told you guys now I have described management of ascites.
මාෂා
Oh.
ඔව් යා මේ මාෂා මේ අර ඇඩඩ් සෝල්ට් එපා කියන සිද්ධියද මේ කෙලින්ම සෝල්ට් රිස්ට්‍රික්ෂන් කරන එකද?
Yeah. No added salt කියන එක තමයි salt restriction කියන්නේ.
හා. ඒ කියන්නේ completely salt restriction ද නැත්නම් no added salt ද?
No added salt. ඒක තමයි salt restriction කියලා කියන්නේ.
Right.
Jana, understood?
Thank you.
Huh? No, but here it is only salt restriction. No, you said
It's the
added.
same. No added salt and salt restriction are the same.
Okay.
How do you manage ascites, Jana? If there is a patient with ascites, how do you manage?
First, we have to find out what is the cause for ascites and do the salt restriction, and we have to check the we have to do we have to take the ascitic, the paracentesis to see the albumin level and give spironolactone.
Excellent. So salt restriction, and then what do? You give spironolactone and furosemide.
Spironolactone, yeah, furosemide, and take the ascitic fluid for yeah,
Culture and full report.
culture
What do you call
full
that
report.
process where you remove ascitic fluid from the abdomen?
Paracentesis.
Synthesis.
Good.
Huh?
So if there is a patient with refractory ascites, what do you do?
We give albumin.
Okay.
Yeah.
What else?
No, we
Mostly
do
albumin.
tips.
You don't really give
Tips.
albumin. Any other cause these things you do? You give albumin when
Tips.
you remove a lot of ascitic fluid, right?
Tips. No tips.
Yeah. So what does tips do in refractory
It
ascites?
it connects mm, it creates a shunt between it was okay.
Yes, excellent. So usually, what tips does is it causes a shunt between the portal vein and the IVC,
Yeah.
right?
Okay.
So what is the only complication of tips you can have?
Complication. I can't remember.
The problem
Can
with
you?
tips is you can get hepatic encephalopathy.
Oh,
Remember,
okay. Okay.
when you get hepatic encephalopathy, what happens? The patient can die.
Uh,
Understood?
yeah.
Okay, so we'll go to the next one.
Yes.
Regarding post-streptococcal glomerulonephritis. Okay, so where do you learn about post-streptococcal glomerulonephritis a lot?
Nephritic syndrome.
In
Nephro.
nephritic syndrome and in pediatrics, no?
Yeah.
Yeah.
Okay. It is an immune complex reaction. True or false?
Oh, ne?
True.
Hmm?
True.
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 What sort of hypersensitive reaction is this? Type 2 or type 3?
Type
Type
2.
2 no? Antibody එකනේ.
Type 2 or type 3? It is type 3 always. What is the example of type 2 hypersensitivity reaction? මේ දෙක හැමදාම අහනවා MCQ.
අර ඇන්ටිබොඩි හදලා ඒ නෙමෙයි
Antibodies වලින් what is the
IgA.
බොඩිස් වලින්
okay, IgA is also I don't know whether IgA is actually type 2 or type 3. I'll have to check on that. But what is the most common antibody mediated hypersensitivity reaction?
romatic
Yeah.
Type 2 hypersensitivity.
cardiac
Rheumatic heart disease, guys.
romatic card ඒක තමයි
මට අහුන්නේ බං ඔබ කියප එක.
අඩ මම හෙවින් කිව්වේ මට ෂුවර් මට නිකන් බය බය වගේ මං කිව්වේ
So IgA nephropathy hypersensitivity type is check. I think it's 2 and 3 both combined. It's a type 3 hypersensitive reaction apparently. Okay? So IgA is also similar to this. Understood, Jarna?
Yeah. Okay.
So if it is nephritic syndrome, remember it is type 3 hypersensitivity, right?
Mm.
Okay. Majority have poor prognosis. True or false?
False, no?
False.
true no
False.
false
90% will recover.
Recovered.
Okay. Make a podi කට්ටියගෙත් එහෙමම තමයි. Elevated C3 and C4 levels. True or false?
False.
False.
C3 මොකද්ද මේ අඩු වෙනවා
C3 reduces, C4 levels are normal.
normal no
Yeah. Histological type will be focal segmental glomerulonephritis. True or false?
No.
What type?
මොකද අනිත් එක මේ
Acute diffuse proliferative.
acute diffuse.
Proliferative glomerulonephritis, right?
Mm.
Pulmonary edema is a complication. True or false, Jarna?
Not sure.
Not sure.
True. Why? Because this can cause fluid overload due to renal failure, and this can also cause hypertension. So if there is a hypertensive emergency, this can present as pulmonary edema. Understood?
Okay.
Okay. So we go to the next one. Which drugs reduce progression of diabetic kidney disease? Now I have told you guys this multiple times. I have told you about microalbumin urea. Drugs which reduce microalbumin urea. I have told you guys about CKD progression reducing drugs also multiple times in previous MCQs. So if you guys don't get this, I will be really angry. Okay.
Yeah.
What drugs reduce progression of diabetic kidney disease? Glycoside. True or false?
False, no?
False. Rosuvastatin. True or false?
ඒක නම් කිව්වේ ඒක නෑ නේද?
Okay.
No.
Aspirin.
But like
True or false?
එකක් නෑනේ.
False.
no. False, no.
Dapagliflozin. True or false?
SGLT2 එකක් නේ. Oh, right. True.
Excellent. Ramipril. True or false?
ACE inhibitors and ARBs. True, no?
True.
Right. So what are the drugs which reduce microalbumin urea? SGLT2 inhibitors.
ACE,
inhibitors,
ACI, and ARP.
Right. Okay. So rosuvastatin, actually there is contradictory evidence, but regarding rosuvastatin reducing CKD is a bit problematic, right? CKD progression reducing right? Understood?
Okay.
Yes.
Right. What is the drug best statin of choice for patients with end-stage kidney disease? So this can be taken as false. Best drug for patients with statin drug for patients with diabetic kidney disease?
Yes. Robust.
No. Best statin for end-stage renal failure patients, and rosuvastatin is really good. Up until CKD stage 3 we can give. However, after CKD stage 3, 3B, 4 and end-stage renal failure, best statin is atorvastatin, right? They have identified that atorvastatin causes reduced progression of renal disease. Understood?
Yes.
Okay, so today 10 MCQs are finished. Any questions you guys have from these MCQs? Now, I hope you guys identify that most of these things, that most of the topics we have discussed have come from the previous MCQs. Did you notice that?
Yes.
Yeah. Oh.
Only like few were there which we didn't know.
Right?
Mm.
Go through the recordings, please, and you go through the past MCQs, and you will definitely be able to do it. Okay? So that's it.
මචං ඔබ දැන් අරක මේ පීඩ් එකේ 18 එකේ බං අර එඩිට් කරපු එක දැම්මේ නෑ නේද?
ඒක මම දානවා හිට. අද දානවා.
Okay, bye. Okay, thank you.
Okay.